Our next speaker is Dr. Ambika Shetty. She is the Medical Director, Cataract and Refractive Surgeon at Geethanjali Eye and ENT Hospital, Thiruvananthapuram. She'll be talking about taming the floppy iris, and also she'll be sharing essential tips and tricks for IFIS cases. Over to you, ma'am.
A warm good morning to all of you. So, is this floppy iris situation a challenge for you when you operate? Yeah? Yeah. So, it's usually in the beginning stages of my career, I have encountered it intraoperatively, and that is when I've always reflected and thought, oh, I should have been a little more careful with the history. So, that is why I wanted to present this topic here. So, we know that intraoperative floppy iris syndrome is characterized by the triad of iris billowing, intraoperative meiosis, and iris prolapse through the phaco and side port incision. Most common cause is that the patient is on alpha-1 blockers. So, especially the medicine that is tamsulosin. Tamsulosin has the highest affinity for alpha-1 blocker. So, this history is very important. So, even if you have missed, it's important to ensure that your counselor has it on her checklist. So, please do not miss this history. Majority of patients, they may think that some of them may be aware, some may not be aware, they might not have been counseled, that they may tell you all other histories but not the history of alpha-1 blockers. So, sometimes even ladies are on these medications. So, please be careful and take a history and ensure that your counselor takes the history as well. So, compared to the Indian and overseas population, more Indian population, that is almost 4.7% of patients are on alpha-1 blockers, and compared to overseas it's only 2.3%. Actually, if you see the statistics in Kerala, much more people are on alpha-1 agonists. In our practice, we see that at least 1 in 20 male patients or sometimes more are on this medication. So, the complications may be as simple as iatrogenic iris injury. Sometimes it may be PC rent, vitreous loss. Sometimes very severe complications, hyphema, iridodialysis can also happen. So, we should always be, we should anticipate this condition and be prepared for that. If you want to classify the severity of IFIS, it can be mild when it is characterized by only iris billowing, moderate when there is iris billowing and either meiosis or prolapse to the side ports and main incision, and severe it is characterized by all three features, that is iris billowing and meiosis and also prolapse through the main and side port incisions. It's important to understand in your preoperative examination what is the exact dilatation, what is the maximum dilatation that the patient achieves. So, as I said, it's very important to take the proper history, examine and have a standard protocol to manage this condition. So, when you start your surgery, ensure that the length of the incisions is adequate enough. So, the main incision should be at least 2 millimeter long if you are anticipating a case of intraoperative floppy iris syndrome. Also, you should make sure the entry is anterior to the iris root. Please ensure that, yeah, I had paused it. Yeah. So, please ensure that the rexus size is adequate so that all your procedures are comfortable. And when you are doing the hydrodissection, please be gentle because many of the times we see that the prolapsing starts during the hydrodissection itself. And once you start the phacoemulsification, depending on what is your technique that you are comfortable with, either it could be a stop and chop or a direct chop, whatever you are comfortable, you can do that. In my case, I would prefer a direct chop in case of IFIS, because you are injecting lesser fluid below the level of the iris. So, that is why I would prefer a direct chop. And also you should ensure that when you are emulsifying the nucleus fragments, it could be slightly above the plane of the iris. so that you avoid the fluid currents going below the iris and minimize the possibility of the iris prolapsing out through the side ports. Also, which viscoelastic to be used in such cases? It's important to use a viscodispersive viscoelastic. So, this will also tamponate the iris down and ensure that it is away from the wound margins. So, in case you have an iris prolapse such as this, you go to the main port and then reposit the iris back and then go ahead with the surgery. So, preoperatively you can use medications such as atropine eye ointment 1%. You can use atropine drops or homatropine or cyclopentolate drops. Also NSAIDs are preferable. In my case I use homatropine drops for 2 days before the surgery, and intraoperatively you can use drugs such as phenylephrine, lignocaine and adrenaline to maintain the intraoperative mydriasis. And ocular OVDs, as I said, you can use, it is a must to use dispersive viscoelastics. You can also use a combination of dispersive and a adaptive viscoelastic. In certain cases, you start off with the surgery, the pupil is well dilated, but as the surgery progresses, you notice that the pupil starts becoming smaller. In such cases, it's better not to hesitate. Go ahead and place a mechanical expansion device. In this case, I have used the BHEX device. Apart from giving a mechanical dilatation to the pupil, it also ensures that it reduces the billowing to some extent. So, it's a very relevant in a case of IFIS. Even if you have a medium dilatation, if you use a mechanical expansion device, it will definitely make your surgery much simpler. So, in some cases the nucleus is very hard and you may not be able to get maximum dilatation with the mechanical expansion device. So, you can also go ahead and use iris retractors, iris hooks. So, in this case the nucleus was very hard, so I have used iris hooks, and also I have performed a SICS for this patient because this would have been more appropriate for that particular patient. So, it is also important to take that clinical decision depending on the preoperative dilatation. If the pupil is very small, then you can go ahead with the SICS procedure as well with iris hooks. So, it is important to anticipate IFIS before surgery. As I said, it is important to ensure that this is always mentioned in your checklist. Even if you miss, make sure that your counselor has taken the history whether the patient is on any medication that can precipitate IFIS. And it is important to take preoperative prophylaxis so that you are well prepared. And OVDs should be used appropriately to prevent iris prolapse. Hydrodissection and hydrodelineation are two maneuvers which represent more risk of iris prolapse. So, you should be very careful during these procedures. Thank you.
Thank you, ma'am, for sharing your tips on management of IFIS cases.
It was nice presentation. I think if you lower the intraocular pressure by giving Diamox before, it will help reducing the risk of iris prolapse. What is your say on this?
Personally, I am not using Diamox, so I don't know the difference. But if during the procedure I feel there is more of thrust and positive pressure, I would reduce the bottle height and reduce the parameters.
So you now next time you give the Diamox and see, because I have started giving Diamox, especially not only in this floppy iris syndrome cases, but the cases where the pupil is not getting dilated, or when the blood pressure is on on a little higher side, or if the patient is anxious, if the patient is having fat and it's short neck, I have started giving Dimox to such patients, and I felt the difference. So it gives you a little lower intraocular pressure during the surgery, and you are manuring, especially with the shallow anterior chamber and the iris coming again and again. I think if you reduce the intraocular pressure, the manuring become much easier. That's what my personal feeling. What's the house says on this?
Yeah.
I give 250 for all cases on the morning of surgery.
Okay. I think that's a useful tip. I can try. I'll definitely try it for my next
Because
patient.
we never give Dimox
Yeah.
usually, but then all my high risk cases, I make sure that I will give the Dimox. I
Okay.
don't know, it's giving me mental satisfaction or really. So what about
Okay.
injection mandatory? That's true, but then it doesn't work immediately. You are going to finish up in surgery in 10 minutes, and by the time when it all starts working, you will be over. You can give pre-op.
Yeah.
But then you have to take IV and everything. So giving the Damox, like patients, sometimes they are a little bit worried about the pricking. So that's why I took that Damox as in 1 hour before the
Cardiac patients, I think you should give molasses also along with it. Otherwise, patients having heart failure and all that.
Yes, definitely. That
Yeah.
even that sulfa allergy and everything you have to take care. That the routine protocol for Damox, you have to see whether that Damox you can give it or not.
And you have to anticipate diagnosis also.
Yes.
So, thank you.